Okay, now let us start with the chapter 73 of your Apurba Sastry Essentials of Microbiology, which is about viral meningitis. Now, this what is viral meningitis? Obviously, again, the inflammation of the meninges of the subarachnoid space caused by viruses, typically milder with a better prognosis than actual bacterial meningitis. Now, the etiology, the major agents are enteroviruses like Coxsackie virus, ecovirus, para-ecovirus, and EV71. These cause more than 85% of virologically proven cases. They can be herpes virus infection like HSV1 or 2, varicella zoster virus, EBV, and CMV. These SV and VZV occasionally produce an encephalitis picture. CMV may lower CSF glucose. There can be arboviruses like West Nile or Japanese encephalitis virus. They are more likely in travelers or during vector-borne outbreaks. And LCM virus is linked to exposure of to rodent urine or droppings. And there can be other miscellaneous viruses like mumps, measles, influenza, and HIV, whose incidence has fallen with the vaccination or the antiretroviral therapy axis. Now, about the epidemiology, age groups at higher risk are children under 5 years of age and the elderly. As you have said already, that meningitis is mostly bacterial, but yes, in less than 5-year-old children and elderly in which immunity is compromised, viral meningitis can also occur. Again, it can occur in immunocompromised hosts like malignancy, transplant, advanced HIV, steroid, or biologic therapy. The transmission usually involves a close personal contact like respiratory secretions, fecal-oral route for enteroviruses. About seasonality, the late spring to early autumn transition period is the peak enterovirus and arbovirus activity period. The incidence is of viral meningitis is more than bacterial meningitis, but many outpatient cases go unreported because of mild self-limiting course. So what we see in the hospitals more are the bacterial meningitis cases because they have a severe course. Now the clinical manifestations. The typical triad seen is fever plus headache, often frontal or retroorbital, and meningismus is there, which is stiff neck but less marked than bacterial meningitis. Additional common features involve photophobia, nausea, vomiting, irritability, lethargy, and poor feeding in infants. Red flag, but is not typical for pure meningitis. They can be seizures, focal deficits, profound confusion, or coma. We have to go to think about encephalitis. Okay, they can be meningoencephalitis, brain abscess, or non-infectious mimics can also be there. What about the lab diagnosis? We have to do a CSF profile in which opening pressure is seen. In viral pattern, the pressure is normal to mildly increase, can be 100 to 350 millimeters of water, and markedly raised suggests bacterial or fungal cases. Now, appearance of CSF is clear, turbid suggests bacteria. Cells are 225 to 500 cells per microliter, mostly lymphocytes. Early less than 48 hour neutrophil predominance is there in EV and West Nile virus. Proteins are normal or mildly increased like 20 to 80 mg per dl. CMV, HSV cases it can be higher. Glucose is normal, ratio more than 0.6. Decrease is uncommon, classically can be seen in CMV. And about gram stain, no organisms will be stained but we have to do gram staining still to rule out partially treated bacterial meningitis. Now about the molecular test, in PCR, singleplex, multiplex or real-time PCR is the gold standard. It has high sensitivity and is rapid. Blood, stool, throat PCR is helpful for enteroviruses. Film array meningitis or encephalitis panel is checked for automated nested multiplex PCR detecting 14 common bacterial or viral agents in 1 hour. Sensitivity is more specific than culture, especially if CSF collected after 2 days of symptoms or after antiviral therapy. Now, what about viral culture? Low yield from CSF or viruses, they are still performed in reference labs for epidemiology. Enteroviruses can be cultured from throat, swab, or stool, but fecal shedding may represent past infection. Now about this, of course, viral agents grow on live hosts. Okay, like so, say egg yolk culture or mice line culture. Now, serology and antibody test is useful for arboviruses like IgM capture ELISA for West Nile and has a limited value for ubiquitous viruses like HZV and VZV. HSV, herpes simplex virus, and VZV, varicella zoster virus. There can be oligoclonal bands which may appear in some viral infections. These are non-specific and are also found in Lyme, neuroborreliosis, and multiple sclerosis. What about the management? Supportive care is by adequate analgesia, antipyretics, antiemetics, hydration, and electrolyte balance. Specific antivirals involve acyclovir IV or high dose PO for HSV1 or 2, severe VZV or EBV. We have to start this therapy empirically until HSV ruled out if suspicion is high. Now, ART optimization has to be done for HIV meningitis. We have to initiate or continue HAART therapy. And prognosis, majority recover fully within 7 to 10 days. Sequelae are rare except in neonatal HSV, severe VZV, or arboviral neuroinvasion. Next up is the non-polio enterovirus Piconaviridae category. Taxonomy and general points. It's from the family Piconaviridae, non-enveloped icosahedral with a single strand RNA. Two medically important genera are enterovirus and rhinovirus. Enterovirus replicate initially in the oropharynx and gut. So these have a feco-oral acquisition. Then it leads to viremia and target organs are CNS, heart and skin. The major human enterovirus groups and serotypes are Coxsackie virus A, serotypes 1 to 24 except 15, 18 and 23. Coxsackie virus B, serotypes 1 to 6. Ecoviruses more than 30 serotypes. Para-ecoviruses, enteroviruses 68, 70 and 71. EV68 has low respiratory tract infections or pneumonia. EV70 can cause acute hemorrhagic conjunctivitis. EV71 causes hand, foot and mouth disease and severe brainstem encephalitis outbreaks in Asia Pacific region. Now, epidemiology and seasonality, worldwide exposure of the virus is there. Summer monsoon peaks are seen in India. Spreads via feco-oral route, contaminated water, fomites, occasionally by respiratory droplets as well. Most infectious is the subclinical stage. Less than 1% develop the CNS disease. Now, what about Coxsackie virus? The key facts are it is divided into group A and group B. The group A organisms preferentially produce flaccid paralysis and diffuse myositis in newborn mice. It has 21 human serotypes A1 to A24. Exceptions A15, 18 and 23 are no longer classified. In group B organisms, we see spastic paralysis, focal necrosis in heart and pancreas, has 6 serotypes B1 to B6. What are the principal clinical syndromes that they cause in humans? Aseptic meningitis is caused by all B types A7, A9 and others. We see CSF pleocytosis, often neutrophilic in early cases. It can cause herpangina, which is vesicular pharyngitis caused by A2 to 6, A8 and A10. We see painful ulcerative lesions on tonsillar pillars or soft palate. Summer outbreaks are seen in children. Hand, foot, mouth disease caused by A16 classically, EV71 and others. We see vesicles without crusting on palms, soles, buttocks and we see oral ulcers as well. It is usually a self-limiting disease. Next up is pleurodynia, which is Bornholm disease, epidemic myalgia caused by groups B1 to B5, sudden stabbing chest or upper abdominal pain or called the devil's grip. The patient complains as if somebody is holding me from the chest. Okay, next up is myocarditis or pericarditis caused by species B1 to B5. It is a leading viral cause of acute myocarditis in young adults. Next up is acute hemorrhagic conjunctivitis caused by A24 with EV70. Explosive epidemics are seen with subconjunctival hemorrhage, edema and resolves in less than 10 days. Next up is neonatal systemic disease caused by B group. Symptoms are severe hepatitis, myocarditis, meningoencephalitis and high mortality. Last is pancreatitis, which can lead to type 1 diabetes. B4 has the strongest link to this, and autoimmune destruction post infection is seen, which also shows the phenomena of molecular mimicry. Now, the diagnosis and management. Diagnosis is by PCR, throat, stool, or CSF, and paired sera are taken but not very much in routine. Treatment is supportive. IVIG sometimes used for severe neonatal or immunodeficient cases. No licensed antivirals or vaccines except poliovirus EV71 is there. Now, what have we learned till so far? Enteroviruses are the overwhelmingly common cause of viral meningitis. Always we have to send a CSF for PCR. Early neutrophils in CSF do not exclude a viral etiology. We have to repeat tap or rely on molecular assays. And we can also do a gram staining to rule out bacterial cases. HSV should be empirically covered with acyclovir until PCR results are available. Because untreated HSV1 or 2 can cause CNS infections and these have a high morbidity. Coxsackie virus B deserve special attention for the extra meningeal complications like myocarditis, pleurodynia, and pancreatitis. Prevention hinges on hand hygiene, safe water, vector control, and for mumps, measles, flu, on routine vaccination. Okay, now coming to the lab diagnosis of enteroviruses in detail. The Coxsackie, eco, and para-eco infections will be treated hereupon. Specimen choice, it's the throat swab or stool or CSF plus minus blood in neonates. Virus isolation, tissue culture is preferred. Cytopathic effect within 5 to 14 days on RD. Hepatitis 2 or vero cells, we see serotype by neutralization or RT-PCR. Next up is mouse inoculation, historic. Now this has been obsolete due to the all those rising animal laws. It if done, there is intracerebral inoculation of suckling mice, and this produces a flaccid in group A or spastic in group B cases of paralysis. RT-PCR, real-time PCR targeting the VP1 region is done rapid, less than 6 hours, highly sensitive and serotype specific. Multiplex panels are available. In serology, we do neutralizing antibody rise in paired sera, mainly epidemiological, which is slow and has a cross reactivity. Okay, now other non-polio enteroviruses are there, okay, like ecoviruses, enteric cytopathogenic human orphan, which is called, include the serotype 1 to 33 except 8, 10, 22, 23, and 34. Aseptic meningitis and encephalitis is caused by this. We see summer rashes, common cold, epidemic conjunctivitis, and pediatric outbreaks in summer. Next are the para-ecoviruses. They have 16 serotypes, 1 and 2 are eco 22 or 23. Capsid has 3 structural proteins versus 4 in other picobands, and it causes occasional meningitis, neonatal sepsis like illness, respiratory disease. Next, enterovirus 71. Key serotypes are endemic or epidemic in Southeast Asia and is neurotrophic, has large HFMD outbreaks and hand foot mouth disease outbreaks. Brainstem meningoencephalitis can be caused, and polio like acute flaccid paralysis is also seen by enterovirus 71. Next is herpes associated meningitis. HSV, primarily HSV2, causes 5% of viral meningitis. Genital lesion history is common in these cases. It can cause molarate meningitis, which is a recurrent self-limiting lymphocytic meningitis, more commonly caused by HSV2 as compared to HSV1. Occasionally, it can also be caused by EBV. Other HSV neuromanifestations seen are encephalitis in HSV1, Bell's palsy, autonomic sacral neuropathy, transverse myelitis, and Guillain-Barré-like syndrome. The varicella zoster viruses causes concurrent or recent zoster chickenpox, but meningitis can occur without rash. The Epstein-Barr virus may follow infectious mononucleosis. Most commonly, Epstein-Barr virus results in infectious mononucleosis. Atypical lymphocytes may be seen in blood or CSF. CMV, chloroplast mosaic virus, HHV6, these are rare, usually cause disease in immunocompromised cases, and CMV may lower the CSF glucose as well. Now, some information about the arboviral, HIV, mumps, and LCMV viruses, meningitis. Encephalitic arbovirus is seen in West Nile, St. Louis, tick-borne encephalitis, Powassan, Colorado tick fever, California encephalitis. Okay, there can be a history of travel or mosquito bite or tick exposure. The peaks come in the late summers and may present as meningoencephalitis. CSF IgM is useful, PCR window is short. Now, our non-encephalitic arboviruses, they are Zika or Oropau. Next, these are seen in Americans and Brazil people. It can present with mild rash with or without conjunctivitis. This often precedes meningitis. In HIV, acute seroconversion or late stage CN5, 7, 8 paralyses are common. And we have to look for P24 antigen or plasma RNA spike. The mumps virus in unvaccinated children, the late winter or early spring season, the peak of this is seen. 10% occur without parotitis, which is atypical mumps, not involving the inflammation of the parotid gland. That is, without parotitis. LCM viruses seen with a history of rodent urine or dropping exposure, plus minus rash. Rash can be there, cannot be there. Pulmonary infiltrates, orchitis, and alopecia can be seen. Okay, so far having discussed, there can be two pathologic patterns about the viral myelitis. Like what pattern? There can be gray matter myelitis of the anterior horn, and there can be white matter myelitis. What is myelitis? Involves the inflammation of the spinal cord. Now, the gray matter myelitis of the anterior horn is caused by poliovirus EV70, 71, Coxsackie virus A and B groups, West Nile Japanese encephalitis. This causes acute flaccid paralysis, often asymmetric. White matter or the transverse myelitis or leukomyelitis caused by HSV1, 2, varicella zoster virus, cauliflower mosaic virus, influenza, rarely involving HIV, HTLV1. This causes sensory level spastic paraparesis and bowel bladder dysfunction. This can be immune or direct viral mediated. So this was all about the non-polio viruses. Now coming on to poliomyelitis, which is caused by polioviruses. So first up is the morphology and the antigenic types of the virus. This also belongs to family Piconaviridae. It is a non-enveloped icosahedral 28 to 30 nanometer in size. The genome is single-stranded RNA. Capsid contains proteins VP1 to VP4, which is type-specific epitopes on VP1. While poliovirus WPV serotypes are 1, 2 and 3, WPV2 was eradicated in 1999, WPV3 in 2019, only WPV1 still circulates in some countries. Vaccine-derived PV, VDPV is the OPV strain that required neurovirulence. Okay, some strains which were passed on as vaccines, उन्होंने neurovirulence acquire कर ली, which is called vaccine-derived poliovirus (VDPV). What are the pathogenesis steps? First up is the entry by fecal-oral, most common, less chances of respiratory droplet infection. Now, the primary replication is there in tonsils and Peyer's patches. The receptors are CD155. Next up, it results in primary viremia, retroendothelial amplification, and leads to secondary viremia. The virus first circulates in the blood. Next up, ये retroendothelial amplification show करता है, like it goes in the retroendothelial system involving the liver, kidneys. वहाँ से again and spleen, and वहाँ से again it recirculates in the body, causes secondary viremia. इसके बाद क्या होता है? It causes neuroinvasion, enters the nerves, most commonly goes to the nerves via the hematogenous route or may can be going through the neural route. Example, post tonsillectomy, why it can travel in the glossopharyngeal nerves. Next up, it targets the anterior horn motor neurons, which will cause cell lysis and cell body dissolution will be there. Wallerian degeneration and muscle denervation will be there. And finally, it results in pathology usually wider than only weakness. Okay, now what about the clinical spectrum? The incubation period of the disease is 7 to 14 days. Inapparent is in 92% of the cases, in which the patient is asymptomatic but still infectious for other people. There is abortive or minor illness in 5% cases, in which fever, sore throat, myalgia, and GI upset, also called as summer flu, is there. In 1% of the cases, it causes non-paralytic or the aseptic meningitis, in which we see stiff neck or back or CSF lymphocytosis with no weakness. Paralytic in less than 1% of the cases is seen. It causes biphasic meningitic prodrome with a transient recovery, and there is the recurrence with asymmetric descending acute flaccid paralysis. 24 to 48 hours later, we see spinal or limb weakness occurring from hip to the distal area. A characteristic of tripod sign is there, in which we see bulbospinal, diaphragmatic or intercostal muscle weakness with respiratory failure, and bulbar or cranial nerves 9 to 12 are damaged or they function less, causing dysphagia and dysphonia. We have to remember that proximal muscles weaken first, and because of that reflexes are absent but sensation is intact. Now about the lab diagnosis. About specimens, we have to collect 2 stool samples 24 hours apart, which is the gold standard. We have to take the throat swab, CSF and blood in first 3 to 4 days. Next, isolation of the virus is done, L20B and RD on RD cells, serotype by neutralization on RRT-PCR. RRT-PCR differentiates WPV from OPV or VDPV. This is essential for eradication surveillance because many governments worldwide are trying to eradicate polio from the world itself. Now, in CSF, we see mild pleocytosis, normal glucose or protein, which will result in non-paralytic form. Okay, now the management and prevention, no antiviral therapy is there. We have to give the supportive treatment like respiratory support, physiotherapy. Vaccination is the mainstay which is preventing the occurrence of polio these days. IPV or the Salk vaccine was inactivated. It induces serum IgG and prevents paralysis. BOPV, Sabin types 1 and 3 are oral live attenuated vaccines, induces mucosal IgA, but there is a risk of VAPP or VDPV, vaccine derived poliovirus, vaccine acquired polio. Okay, now global polio eradication strategy involves more than equal to 3 OPV rounds plus 2 IPV doses, and acute flaccid paralysis surveillance is there, and environment sewage testing is there, that if somebody is passing the polio virus in the stool or not. Now there is a comparison between the enterovirus versus herpes versus arbovirus. Okay. Now the peak season for enterovirus is late spring or autumn. For herpes 2, HSV2 is year round, and arbovirus is late summer. Okay. West Nile fever virus all comes in arbovirus. Age predilection, enterovirus is seen in infants or children. Okay, HSV2 more seen in young adults or neonates, and arbovirus is seen in all ages, mostly in elderly maybe. Okay, now the CSF cells, 100 to 500 per microliter early PMN and then converting into the lymphocytes are seen in enteroviruses. 10 to 300 per microliter lymphocytes are seen in HSV2, and 50 to 500 per microliter lymphocytes are seen in arbovirus. The therapy is supportive for enterovirus, acyclovir therapy for HSV2, and again supportive therapy for arboviruses. Prognosis for enterovirus is excellent. For HSV2 is usually good, but it can recur. And for arboviruses, it's variable. Neurosequelae are possible even after treatment. Okay, so now what have we learned in this part? PCR VP1 is the diagnostic workhorse for all non-polio enteroviruses. Mouse inoculation is historical. HSV2 causes recurrent mollaret meningitis, which have to be suspected in genital lesion history. Viral myelitis is either gray matter, AF, acute flaccid paralysis by enteroviruses, or white matter, transverse paralysis by herpes virus. Polio remains endemic only for WP1. Dual IPV and OPV strategy is critical to end game. And always we have to assess meningitis patients for red flags of encephalitis or myelitis. Okay, the management and prognosis differ in both the cases. Now continuing the poliomyelitis, paralytic poliomyelitis, the risk factors and clinical pearls. The risk factors are higher attack rate in older children and adults, in pregnancy, in heavy exertion just before CNS symptoms, and local trauma or intramuscular injections, which can cause provocation poliomyelitis, in post tonsillectomy, which predisposes to bulbar disease. The cranial nerve palsies may accompany spinal weakness, yet sensory function remains intact. About the typical pattern, asymmetric descending flaccid paralysis, proximal muscles are involved first, reflexes are lost but no sensory deficit is there. Now the lab diagnosis of poliomyelitis, very important. First step is virus isolation, which is done by throat swab less than 3 weeks or 2 stool samples 24 hours apart in less than 12 weeks cases, longer in immunodeficient cases maybe. And this is the gold standard for AFP surveillance is virus isolation. Now the tissue culture, primary monkey kidney or L20B RD cell lines are there. There is CP, crenation or degeneration of the cells in 3 to 6 days, and serotype is identified by neutralization or RT-PCR. Now environmental, we have to do C-based testing for WPV or VDPV early warning signs. About serology, neutralizing antibody rise in paired sera 1 to 2 week apart, strictly type specific after the first infection. Molecular or real-time multiplex RRT-PCR targeting VP1 distinguishes WPV1 from OPV like VAPP or VDPV strains directly from stool. About CSF, there is mild pleocytosis, normal glucose or protein is seen, and viruses are rarely isolated from CSF. Now an important part both for microbiology and PSM is polio vaccine. Feature for IPV, Salk or inactivated vaccine, there are 3 serotypes: full 0.5 ml IM or fractional 0.1 ml intradermal is given. Okay, now in Indian schedule, and for OPV, which is the Sabin or live oral, mono, bi 1 and 3 or trivalent were given, but trivalent was stopped in 2016. About the Indian schedule, 2 FIPV doses at 6 and 14 weeks are given. Okay, plus BOPV, and at birth, oral polio vaccine is given. And then 2 FIPV doses at 6 and 14 weeks are given. 1 booster at 15 to 18 months is given. About OPV, 0 doses given at birth and 6, 10, 14 weeks oral polio vaccine is given, and booster is given at 16 to 24 months. Now about the herd or mucosal IgA, it is not seen in IPV but seen in OPV because fecal-oral spread of OPV is also there. So herd immunity is developed due to use of OPV. The use of IPV in outbreak is limited, but OPV remains the vaccine of choice. Safety, now in IPV there is no chance of VAPP or VDPV, so it is safe in immunodeficient cases, but rarely OPV can cause VAPP 1 out of 2.7 million doses. What is VAPP? Vaccine acquired poliomyelitis. The administration of vaccine itself causes polio. That can be there in oral polio vaccine, and also there is a risk of vaccine derived polioviruses, that the virus has undergone mutation and then it's causing polio in the population. So the risk is there in oral polio vaccine but not there in a fractional IPV. Okay, now the cold chain, yes. The cold chain FIPV is stable at 2 to 8 degrees Celsius, but OPV requires 20 degrees Celsius, magnesium chloride, and pH less than 7. Okay, so oral polio vaccine has to be stored at a lower temperature. Now the cost, of course, the cost is higher in FIPV because you have to give the injections and all, while OPV has a cheaper and easier oral dosing. So this was all taken from the National Immunization Schedule by the Government of India. Now what are VAPP and VDPV? You can get a short note or maybe a Viva question on them. VAPP is vaccine acquired polio and VDPV is vaccine derived poliovirus. So the genetic drift from Sabin is less than 1% in VAPP and more than 1% in VP1. About the epidemiology, sporadic in vaccine recipients or close contacts and no community spread is there by VAPP. While VDPV circulates and causes outbreaks, CVDPV is the most common. Global incidence of VAPP is 1 case out of 2.7 million OPV doses. Type 3 is more predominant than type 2. And CVDPV2 predominates in the VDPV part. 365 CVDPV cases worldwide in 2019, 11 CVDPV2 cases reported so far in 2025. Now the about epidemiology, as seen from June 2025, the reservoir are human only. Most infectious is the subclinical stage. Okay, 1000 to 1 child, 75 is to 1 adult. While poliovirus WPV1 persists only in Pakistan and Afghanistan, 6 WPV1 cases in Pakistan and 1 in Afghanistan were reported till the date this video is being made in 2025. CVDPV outbreaks were there. These continue in parts of Africa like Benin, Chad, Ethiopia, and Nigeria, and elsewhere in Africa. Period of shedding is of stool 7 days before to more than equal to 3 weeks after the symptoms. So, and it can be till months in immunodeficient cases. So this is the time for which the case of polio remains active for causing infections. And high risk settings are the areas which have low vaccine coverage, poor sanitation, and are the conflict zones, like any zone which comes under administration of two or more than two countries. So they fight and nobody is taking care of that particular part. So obviously the conflict zones come at high risk for this. Now, what are the global eradication efforts that are being made to eliminate or eradicate polio? Pulse polio immunization. India has adopted pulse polio immunization since 1995. Two nationwide BOPV rounds each winter are carried out, and doses are extra and do not replace routine schedule. So national immunization schedule is followed as it is for FIPV and OPV both. Other than this, for the children's age less than 5, oral polio vaccine are given as extra dose. AFP surveillance, acute flaccid paralysis surveillance is done. More than equal to 2 stool samples collected from every child less than 15 years with acute flaccid paralysis, and we have to check whether this acute flaccid paralysis has been caused by polio or some other species. No polio AFP rate more than 2 upon 1 lakh is a programmatic target. GPEI Endgame Strategy 2019 to 2023. The goals are interrupting WPV1 and CVDPV2. Second, integrating polio functions into broader health systems. And third, containment and certification. Now, the Global Polio Surveillance Action Plan 2025-26 renewed push to finish WPV1 and CVDPV2 transmission. Current status: India remains polio free, certified in 2014. Recent WPV1 case clusters are in Pakistan's Balochistan. These illustrate ongoing challenges of security and vaccine hesitancy. Okay, so this completes your chapter about the viral meningitis, and we have also covered very nicely the poliomyelitis in this chapter. So obviously you can get a big case on poliomyelitis. About meningitis, mostly the cases from meningitis will be bacterial. Okay, there are less chances that you will get a viral meningitis long case. Now there is a exam question like how will you get the case of poliomyelitis? There is a case. 9-week-old infant with asymmetric flaccid leg weakness is there. CSF we see more protein and than glucose is normal, and stool viruses are like Sabin like type 1. So what's the probable diagnosis? The probable diagnosis is vaccine associated paralytic poliomyelitis VAPP. The isolated strain is OPV derived with less than 1% divergence. Lab workup: we will collect two stool samples 24 hours apart and a throat swab. We will inoculate them on L20B or RD or monkey kidney cells for crenation or degeneration CPE. Now the serotype and intratypic are differentiated by neutralization and RT-PCR for VP1. CSF is rarely positive. We have to check household contacts to contact stools also to rule out community acquired VDPV. We have to check whether or not any sibling of the child is taking oral polio vaccine or is infected. Now the available vaccines are IPV inactivated, IM or intradermal fractional. This is safe in all hosts, and OPV live or oral, birth OPV and monthly, and NOPV2. These provide mucosal immunity, but there is a risk of VAPP or VDPV. Okay, now what some short summary. Risk modifiers in polio are age, pregnancy, exertion, trauma, tonsillectomy, and intramuscular injections. These increase likelihood of paralytic disease if viremia occurs. Now, primary monkey kidney culture remains the reference method for surveillance, but RRT-PCR has expedited serotyping and VDPV detection. IPV plus BOPV sequential schedule balances mucosal immunity with safety. Fractional dose IPV conserves supply and improves seroconversion. VAPP is sporadic. CVDPV behaves like wild virus, and robust population immunity is crucial to prevent emergence. With WPV1 now geographically cornered in two countries, Pakistan and Afghanistan, the final hurdles are insecurity, vaccine refusal, and rapid control of CVDPV2 outbreaks. If we are able to achieve this, the virus can be eradicated globally in the coming years. Okay, so this completes your chapter, and next up we will be covering the encephalitis caused by the viruses. Okay, so do make sure to read this poliomyelitis from the book and prepare an answer based on whatever important lab diagnosis and the clinical features are there. Also, an important question can be asked about the vaccination and VAPP versus VDPV in this chapter. Okay, so like, share, subscribe. Thanks for watching. Bye bye.